Hello everyone, this is Isha and I'd like to welcome all of you in today's Cell Talk webinar. In today's session, Dr. Yogita Das will be presenting the paper titled Grading of IDH-mutant astrocytoma using diffusion, susceptibility and perfusion-weighted imaging. Yogita is working at RINIX as a clinical content writer. She is responsible for writing scientific content and clinical white papers on healthcare-related topics with the main focus on oncology and immunology. Yogita has a doctoral degree in life science with Symbiosis International Deemed University Pune, and her research work focuses on diabetes and vitamin D. At Renix, she has gained experience in scientific writing. So, without any further delay, I'd like Yogita to take the floor.
Thank you, Isha, for this introduction. As a part of Cell Talk activity, today I am presenting a research titled Grading of IDH-mutant astrocytoma using diffusion, susceptibility, and perfusion-weighted imaging. This research article has authored by Yang et al. And it has published in the journal BMC Medical Imaging with impact factor 2.822. This research has published in the year 2022, and this research has impact on IDH-mutant astrocytoma grading and the diagnosis. Astrocytoma, it is a type of cancer and that occurs in the brain or the spinal cord, and it accounts for more than 70% of all gliomas. It begins in the cells called astrocytes that could provide support and structure to the neurons. The signs and symptoms of the astrocytoma depends on the location of the tumor. If it occurs in the brain, then it can cause seizure, headache, and nausea. And if it occurs in the spinal cord, it can cause weakness and disability in the affected area. Astrocytoma usually diagnosed with the neurological examination, imaging combination of imaging test and the biopsy. Astrocytoma can be slow growing or the aggressive tumor that grows quickly, and the aggressiveness or the grade of the tumor determines the prognosis and the treatment options. Usually slow growing tumor, it is treated by the surgical resections, whereas for the aggressive tumor, along with surgical resection, radiotherapy and the chemotherapy can be utilized. Astrocytoma can be classified as isocitrate dehydrogenase, that is IDH mutant or IDH wild type. This article has focused on the isocitrate dehydrogenase, that is IDH mutant type of the astrocytoma. What is IDH mutant astrocytoma? It is a diffuse infiltrating astrocytoma with no identifiable borders between the tumor and the normal brain tissue, although it is with the well-differentiated margins during the imaging techniques. According to the 2021 World Health Organization Central Nervous System classification, IDH mutant astrocytoma categorized as grade 2, grade 3, and grade 4 IDH mutant astrocytoma. Usually, it is diagnosed in young adults with median age of 36 years for grade 2 and 3 and 38 years for grade 4 IDH mutant astrocytoma. There are 3 different grades of this astrocytoma on the basis of molecular characteristics and the histopathology. Grade 2, it is well differentiated with low mitotic activity, whereas grade 3, it is characterized by the loss of mature or specialized features of cells or tissue with significant mitotic activity. Both grade 2 and grade 3, it is characterized with the no necrosis or microvascular proliferation and the absence of CDKN2AB homozygous deletion. However, grade 4, it is the most aggressive tumor. It is characterized with the higher tumor cellularity, necrosis, microvascular proliferation, and the CDKN2AB homozygous deletion. There are some present challenges associated with this research area. The accurate grading of IDH mutant astrocytoma is vital to make therapeutic plan and assess the prognosis of patients. But only a handful of the studies focus on the grading of such type of the tumors. Also, the utilization of advanced imaging techniques to assess or to grade IDH mutant astrocytoma are limited. Thus, there is a greater need to evaluate the diagnostic accuracy or diagnostics performance of advanced technology in the utilization of grading of IDH mutant astrocytoma. On the basis of these present challenges, the researchers has put 2 different objectives of their study. First objective was to evaluate usefulness of advanced imaging techniques like diffusion-weighted imaging, that is DWI, susceptibility-weighted imaging, that is SWI, and dynamic susceptibility contrast perfusion-weighted imaging, that is DSC-PWI, for grading of IDH mutant astrocytoma. The second objective was to study the diagnostic performance of combination of these three advanced imaging techniques to improve the accuracy of diagnosis of this type of the tumor. This study was a retrospective study, and researchers had reviewed 107 patients that were coming to the hospital between the period of July 2014 to March 2020. The inclusion criteria was the patient diagnosed with IDH mutant grade 2, 3, 4 astrocytoma confirmed by histopathology. And also the patient should underwent pre-treatment MRI scan, including conventional MRI, DWI, SWI, and DSC-PWI. Out of 107 patients, 63 were male, 44 were female, and they were aged between 18 to 68 years old, with mean age was 40.39 years. Out of these 107 patients, 56 patients were with grade 2, 29 patients were with grade 3, and 22 patients were with the grade 4 IDH mutant astrocytoma. In these 107 patients, the researchers had assessed some values, that is minimum apparent diffusion coefficient, that is ADC minimum, intratumoral susceptibility signal intensity, that is ITSS score, and maximum relative cerebral blood volume, that is RCBU max. ADC minimum, it is obtained from the DWI imaging, and it is used to evaluate tumor cellularity. It is inversely correlated with the tumor cellularity and the aggressiveness of the tumor, because as the aggressiveness of tumor is increased, there is increase in the cell density and the tumor cellularity, which leads to the decreased ADC values. ITSS, it is obtained from the SWI imaging. There is a fine dot-like structure during the image acquisition, and it is used to compute the score, ITSS score, and this ITSS score used to assess the tumor micro-hemorrhage and the vasculature. Then RCB max, this value obtained from the DSC-PWI imaging, and it could provide the vascularity and the angiogenesis information of the astrocytoma. Higher the grade of the tumor, higher the RCB max value. This whole imaging was performed with 3.0 TMR system. The conventional MRI, that is CMRI, it is performed with the sequences of T2 weighted, FLAIR, T1 weighted, and contrast enhanced T1 weighted sequences. Then DWI was performed with a single shot echo-planar imaging sequences, and ADC map was used to calculate the ADC value. ADC value is also calculated with the help of neuroradiologist. Then SW was performed by 3D fully flow compensated gradient echo sequence and reconstruction by combining the magnitude and phase images. And then on the basis of the dot-like structures, ITSS score were computed, and on the basis of ITSS score, the IDH mutant astrocytoma were graded. Then DSC-PWI was obtained with a gradient tree called T2 weighted echo-planar imaging sequences. And then RCBU max value were calculated using the images of the DSC-PWI. RCBU max value were calculated with the help of neuroradiologists, and these neuroradiologists were blinded with the tumor histopathology. These all values were compared between grade 2 versus grade 3 versus grade 4, and grade 2 plus 3 versus grade 4 tumors. Then logistic regression analysis was used to assess the diagnostics performance or diagnostic effect of these total parameters that were obtained from the advanced imaging techniques like DWI, SWI, and DSC-PWI. Then researchers had performed the receiver operating characteristics curve analysis to determine the optimal cutoff for differentiating grade 2, 3, and grade 4. In addition, they have performed comparison of area under the ROC curve to quantitate different variables like ADC value, ITSS, and the RCBU max value. Coming to the results section, researchers have summarized ADC minimum, ITSS, and RCBU max values among the 3 different grades of the IDH mutant astrocytoma. And from this table, we can clearly see that ADC value it get decreased with respect to the grade of the tumor or with respect to the aggressiveness of the tumor. In grade 4, the lowest ADC value it is reported, whereas ITSS and RCBU max, both the values were increased with respect to the grade of the tumor. And here we can observe that highest value of the ITSS and RCBU max reported in the grade 4 tumor. Then they have performed the comparative analysis of these three mean values of these three in the grade 2, 3 and grade 4. Figure A, it is showing the mean value of ADC, and here they have compared their significance, and they have observed that there is no significant level between the grade 2 versus grade 3 comparison, whereas there is a significant for the comparison of grade 3 versus grade 4 and grade 2 versus grade 4. In figure B indicates the mean values of RCBA max, and here also similarly there is no significant difference for the comparison of grade 2 versus grade 3, whereas there is a significant difference for the comparison of grade 2 versus grade 4 and grade 3 versus grade 4. But however, in the case of ITSS, there is highly significant difference for the comparison of grade 2 versus grade 3 also, and for the comparison of grade 3 versus grade 4 and grade 2 versus grade 4. After this, researchers perform Spearman correlation analysis. This analysis they have performed to check the correlation of these three values with the grade of the tumor. And they have reported that ADC minimum, it is significantly negatively correlated with the grade of the tumor. That means as the aggressiveness of the tumor is increased, there is decrease in the ADC minimum value. However, ITSS and RCBV max values were significantly positively correlated with the grade of the tumor. Researchers have added three different figures for the representative figures for the grade 2, grade 3 and grade 4 IDH mutant astrocytoma. This figure is the representative figure of the grade 2 IDH mutant astrocytoma from a 40-year-old man. Figure A, it is the DWI imaging. Figure B, it is the SWI imaging, and figure D, it is the DSC-PWI imaging. Figure A, it is showing that there is highest value of the ADC, and DWI is used to distinguish white matter, a normal white matter from the tumor, whereas B, it is the SWI imaging, and there is no ITSS detected in the tumor. In the figure C, it is the post-contrast T1-weighted image, and it is with the non-enhancing lesions. Figure D, it is the RCBU map, and it shows RCBU value, low RCBU value as a 0.76. This is the representative figure of the grade 3 IDH mutant astrocytoma from a 53-year-old woman. And in the ADC map, we can clearly see the decreased value of the ADC with comparison to the previous figure. Whereas figure B shows obvious ITSS detection in the parietal region, and figure C, it is showing the post-contrast T1 demonstrates, but it is also with the non-enhancing lesions, similarly with the reported in the previous figure. And in figure D, there is increase in the RCB value as 1.19, as we have already seen that in the last figure it was 0.76. This is the representative figure of the grade 4 IDH mutant astrocytoma from a 43-year-old man. And here we have seen a decreased ADC value in the figure A. It is decreased up to 0.916, as the ADC value is decreased with respect to the aggressiveness of the tumor. Whereas there is the detection of ITSS tumor upon SWI imaging in the figure B. And in figure C, there is contrast enhancement they have reported. If tumor picks up the contrast and it becomes bright on the images, then it is the indication of the aggressiveness of the tumor. When there is an aggressive tumor, then it comes with the contrast enhancement. And in figure D, that is in the DSC-PWI imaging of IDH mutant for astrocytoma, they have detected RCB value as 4.68. It is increased as compared to the previous two figures. Then researchers have performed receiver operating characteristics curve to distinguish various grades of the IDH mutant astrocytoma. And here they have calculated the area under the ROC curve for ADC, ITSS, and RCBU max in alone and also in combination. And they have reported larger area under the curve for the combination of these three values with comparison to the three values alone. On the basis of this ROC curve, researchers have calculated the cutoff value of the ADC, ITSS, and RCBU max with respect to sensitivity and specificity. They have calculated a cutoff for ADC minimum at 0.94 with 100% sensitivity and 85% specificity, whereas cutoff for ITSS was 1 with around 82% sensitivity and 80% specificity, whereas cutoff for RCBU max was 3.84 with 94% sensitivity and around 95% specificity. They have reported a higher 100% sensitivity for the combination of ADC and RCBU max, combination of ITSS, RCBU max, and the combination of these three values. They have 100% sensitivity, whereas their specificity was around 89%, 86%, and 93% respectively. They have reported highest specificity with the combination of these three values. Then they plotted area under the curve for these three values in alone and in combination. Figure B is showing the ADC, ITSS, RCB value, area under the curve for these three values to differentiate grade 2 plus 3 from grade 4 IDH mutant astrocytoma. And here they have observed the larger area under the curve for RCB value that is shown in the orange color and ADC minimum value that is shown in the blue color as compared to the ITSS that is shown in the green color. Whereas in case of the possible combinations of these three values, there is a larger area under the curve for all the combination, and the largest area under the curve observed for the combination of these three values. Coming to the discussion section, from the results obtained, they have found that there is a significant difference of ADC, ITSS, and RCBU max values between grade 2 plus 3 and grade 4. But there is no significant difference of ADC and RCBU max between grade 2 and grade 3. This discrepancy may be occurred due to the fact that enrolled patients were different and under their previous investigation, they did not consider the IDH mutational status of the gliomas. Thus, from the obtained results, they can propose that the combination of these three values, that is ADC minimum, ITSS, and RCBU max, that were obtained by using the advanced imaging techniques, these values showed a better trend to distinguish grade 2 or grade 3 from grade 4 IDH mutant astrocytomas. This study has some limitations. It is a retrospective study and it was conducted at a single center. Because of this, it may lead to the selection bias. And also the findings cannot be generalized to the whole population, as this study was conducted at a single point. It was a single point study. So the researchers proposed the reproducibility of such studies with a larger data set. Also, this study associated with other limitations. As for this retrospective analysis, the DSC-PWI acquisition was suboptimal and was not obtained according to the national consensus recommendation. The major limitation was the fact that they have not considered the genetic alterations such as CDK into AB and CDK4 because of the lack of the relevant molecular information from the current study. Coming to the conclusion, from the result obtained, they have concluded that the advanced imaging techniques like DWI, SW, and DSC-PWI, they are useful to assess the tumor grade of the IDH mutant astrocytoma. Also, combination of the values ADC minimum, ITSS, and RCBU max value that were obtained by using these advanced imaging techniques may use to enhance the diagnostics performance of the grading of IDH mutant astrocytoma. This research has impact on the diagnosis and grading of the IDH mutant astrocytoma, as there is a lack of the diagnostics precision of the grading of IDH-mutant astrocytoma. So by using the combination of these three values or the combination of these advanced techniques, there can be the enhancement or the improvement in the diagnostics efficacy of the grading of IDH-mutant astrocytoma, and it will help to distinguish grade 2 and distinguish grade 4, that is the most aggressive tumor with poorer survival rate, from the grade 2 and grade 3 astrocytic tumors. Thank you so much. Thank you so much for your kind listening. You can find me at yogita@trainings.org.
Thank you, Yogita, for this informative talk. Now I'd like to open the floor to the audience for any questions. Nupur asks, nice talk, Yogita. How does this grading help in the treatment of the disease? It does not consider genetic alterations beyond IDH and CDKN2A.
Actually, it is the major limitation of this study. They have not considered the genetic alteration that is the most important in the astrocytic tumors. But they have greater diagnostics. But they have proposed that by using these advanced imaging techniques, there is improvement in the diagnostics, or the improvement in the differentiating grade 4 from grade 2 and grade 3. And actually there is difference in the treatment strategy for these three grades of the tumor. So if there is a precision diagnostic, if there is a precise diagnosis of these three grades, or the we can say the differentiation of these three grades, then that may help to plan a treatment strategy for that patient. If it is with a grade 4, that is the most aggressive tumor, then in that case the doctor has to opt for the other aggressive chemotherapy and the radiotherapy along with the surgical resections. So such type of the grading can help to choose the right treatment option according to the grade of the tumor.
Thank you, Yogita. Hope that clarifies your doubt, Nupur. The next question is from Vijay. He asked, could they differentiate among different glioma subtypes, or only pre-selected, pre-diagnosed astrocytomas were used for grade differentiation?
Pardon?
Could they differentiate among different glioma subtypes, or only pre-selected, pre-diagnosed astrocytomas were used for grade differentiation?
Actually, they have used the patients with the actually those patients were with the histological confirmation of the diagnosis of IDH-mutant astrocytoma. They have not differentiated other gliomas. They have selected only those patients were diagnosed with the grade 2, grade 3, or grade 4 IDH-mutant astrocytoma, and their diagnosis was also confirmed by the histopathology.
Thank you, Yogita. I hope that suffices your doubt, Vijay. I don't see any more questions. Before concluding today's session, I'd like to inform you about our next webinar, which is on 31st of January 2023, to be presented by Pawan Kumar Etta on the topic Brain MRI Meningioma Tumor Detection Using Radiographic Image Processing Techniques. That brings us to the end of our Cell Talk today. Thank you everyone for your kind attention and time. Hope to meet you in our next webinar on 31st. Thank you.